Welcome to the November 13th meeting of the Washington Hospital Board of Directors. I'd invite you all now to stand for the presentation of our colors. We have with us tonight the color guard of the Fremont Army Recruiting Station.
Set. Arms. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Audience may be seated. Grateful for these men to be with us tonight. They're under the direction of Sergeant Johnson. And we appreciate them being here and helping us celebrate Veterans Day. We'd now like to have Kimberly Hartz, our CEO, give us some words on in commemoration of this event and of operations in the hospital in regards to that.
Thank you, Dr. Stewart. I want to say every year our nation celebrates Veterans Day on November 11th. It is a date that is set aside to honor those who have served our country. At Washington Hospital Healthcare System, we are proud to carry on this tradition by recognizing members of the Washington Hospital family who have served in the armed forces. These men and women are veterans and reservists. Their service and sacrifice keep our country safe and free. These men and women represent 88 Washington Hospital Healthcare System employees or members of our medical staff. To honor their service, we have a commemorative Veterans Recognition Wall here in Washington West, just down the hall from these auditoriums. The wall lists the names, military branch, rank, and length of service of our veterans. I invite each of you to please visit the Washington Hospital Veterans Recognition Wall. This year, it was our honor to add the following names to the recognition wall. Timothy Barnett, a staff nurse 2 in the emergency department who served 8 years in the Army and held the rank of Staff Sergeant E6. Tim was stationed in Germany for 3 years and in Alaska for 2 years. While serving in the military, Tim got to see the world. This experience has helped his nursing career tremendously as he cares for diverse populations. Tim was a combat medic in the reserves for 5 years, at which time he went to nursing school. He's been a nurse for almost 25 years. Angel Castro works in our laundry department as a per diem employee. He served 4 years in the Marines and held the rank of Corporal E4. Angel was trained as a firefighter and was stationed in Japan and Arizona. Today, he is a full-time student studying mechanical engineering at Chabot College. He plans to transfer to a local university to complete his degree. Timothy Coyle is a staff nurse 2 in the emergency department. He served 4 years in the Marines as a Corporal E4 from 1991 to 95, which was the beginning of the first Gulf War. Tim did a tour in the Persian Gulf and was deployed to Iraq, Kuwait, and Saudi Arabia. He was on the closest landing force unit during the Somalia conflict. As a result, he was part of the first American unit to go into Somalia for United Nations peacekeeping. Tim went through Special Forces training to become a reconnaissance Marine with Special Combat Scuba certification. He was stationed at Camp Lejeune in North Carolina. Dr. Christopher Kuhl is an anesthesiologist on our medical staff. He served for 12 years in the Air Force and held the rank of Major 04. He was Director of Trauma Anesthesiology at Bagram Air Force Base in Afghanistan. In that role, he established clinical practice guidelines for the anesthetic treatment of major battlefield trauma. He personally saw and cared for 200 plus critically injured trauma patients, including 3 mass casualties. He also held a staff anesthesiologist position at Travis Air Force Base. Upon separating from the Air Force, he received Air Force Commendation Medal for his valor and service. Lastly, Joshua San Diego. He is a member of our laundry department team. He served in the Army 2 years and held the rank of Corporal E4. He trained as a combat engineer and was stationed in Hawaii, Guam, and the Philippines. In addition to working at Washington Hospital, he also works for CAL FIRE. He will be starting EMT school in January and plans to eventually become a firefighter in the Bay Area. I want to personally thank each of these veterans and the many others whose names were added to the Veterans Recognition Wall in previous years for their dedication and commitment to our country. Their service is sincerely valued and appreciated. I also thank our veterans for choosing Washington Hospital. At Washington Hospital, we know that hiring men and women who have served in our military or continue to serve in our military adds talented professionals to the hospital healthcare system family. This is a good opportunity to remind everyone that Washington Hospital has a leave policy that allows members of their armed forces or National Guard to be granted military leave from work for the period required when called to active duty for training, in active duty training or active duty. Our military leave program allows servicemen and women who choose to continue their military service to be able to do that without fear of not having a job when they return, and without facing financial burdens that are often created when leaving non-military jobs to serve our country. No matter what branch our military men and women serve in, whether peacetime or wartime, whatever their job path or how many years were served, military men and women commit themselves to service. Their bravery and selflessness is valued and respected at Washington Hospital Healthcare System. It is that commitment to service that guides our support of our military personnel and veterans. We greatly appreciate the sacrifices they have made to serve our country at home and abroad. We thank each of them for their selfless dedication to our country and our freedom. Again, I want to thank the Color Guard, the members of the Color Guard from the Fremont Army Recruiting Station for helping us to observe Veterans Day today. We appreciate you coming. Thank you.
Thank you, Kimberly. I also would like to express my thanks and the thanks of the board for you men coming here this evening and presenting the colors. Thank you very, very much. This is from the Fremont Army Recruiting Station here in Fremont. Again, thank you very much. And we'll allow you to be dismissed at this point.
Right shoulder. Off. Right. Please. Forward. Up. Left. Left. Left.
It's a wonderful thing to have those people with us tonight. Appreciate them doing that. It's a very, very wonderful thing to celebrate our veterans at this time of year. They do an incredible service to all of us. We're ready now to proceed with the rest of our meeting. Dee, if you could take the roll, please.
Director Stewart,
Present.
Director Nicholson,
Present.
Director Wallace,
Present.
Director Epen,
Present.
Director Yee. Present.
Thank you, Dee. We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda later in the meeting under the action items. Does anyone want to remove any agenda item from the consent calendar? Seeing none, I'd like to entertain these items just a little bit separately. Items B and C, I think we should entertain first.
Mr. President, I wish to recuse myself from voting on items B and C, resolutions pertaining to Fremont Bank.
Thank you, Mike. May I now have a motion on the consent calendar for items B and C?
In accordance with the district law policies and procedures, I move that the Board of Directors approve the consent calendar items B and C.
Dee, if you'd take a roll on that for me?
I'll second that.
I'm sorry, we need a second. We have a motion and a second. Now, Dee, if you would take the roll, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Epen,
Aye.
Director Yee. Director Wallace is recused.
Right. So that item passes. Now we'll invite Mr. Wallace back in the room. Is he within earshot?
He's not far.
So, inviting Mr. Wallace back, at this point, we'd entertain a motion on the consent calendar, items A, D, E, and F.
So moved.
I'll second that.
So we have a motion and a second. D, if you take the roll for us, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Epen,
Aye.
Director Yee.
And that motion passes. So we're now ready for communications. Are there any oral communications this evening?
There are none.
There are none. Seeing none there, we'll go to written communications, and that is from Dr. Killerow. Welcome, Dr. Killerow. It's good to have you with us.
Thank you. We have the credential action items that I'd like to present. We have two physicians for an initial two-year appointment. Dr. Wahid Ibrahimi is an internal medicine hospitalist, and Dr. Nicholas Prionis is a radiation oncologist. Both are asking for provisional active status, and they are both asking for temporary privileges as well. We don't have any one-year initial appointments, no locum tenens, no 30-day extensions. We do have two physicians asking for a waiver request, Dr. William McNutt from Intensive Critical Care, and Dr. Yesha Patel from Family Medicine. We have several two-year reappointments. Jennifer Biza is a cardiac perfusionist, Dr. Sangeeta Balakrishnan, cardiologist, Dr. William Busby, internal medicine, Dr. Harman Chawla, infectious diseases, Dr. Joan Chen, anesthesiologist, Dr. William Degoni, general surgery, Dr. David Gorsalowski, dermatology, Dr. Sanez Kayan, reproductive endocrinology, Dr. Scott Kramer, OBGYN, Dr. William Paik, telemedicine radiology, Dr. Simin Siddiq, internal medicine, Dr. Saif Siddiqui, telemedicine radiology, Dr. Kelsey Smith, internal medicine, Dr. Philip Young, internal medicine hospitalist. And for one-year reappointments, we have Dr. Rajiv Ahuja, internal medicine, Dr. K.S. Chen, interventional cardiology, Dr. David Cheng, hematology oncology, Dr. John Yako, pathology, Dr. Tang Li, cardiothoracic surgery, Dr. Anmol Mahal, gastroenterology, Dr. Marco Pavesi, internal medicine. For non-reappointments deemed to have resigned, we have Dr. William Clausen, anesthesia pain management, Dr. Marilee Schuhard, anesthesia pain management. For transfer in staff category, we have Jacqueline Doe, nurse practitioner with emergency medicine, Dr. Satinder Kaur, internal medicine hospitalist, Dr. Tang Lee, cardiothoracic surgery. For completion of proctorship prior to eligibility for advancement in staff category, we have Dr. Brian Beal, emergency medicine, Dr. Zarlakat Wayand, emergency medicine. Completion of proctorship and advancement in staff category, Dr. Satinder Kaur, internal medicine hospitalist, Dr. Tang Lee, cardiothoracic surgery, pending thoracic endovascular aortic aneurysm stent graft privileges. Extension of proctorship and provisional category, Dr. William McNutt, intensivist, and Dr. Yesha Patel, family medicine. Deletion of privileges requested by Dr. Tang Lee, cardiothoracic surgery, and Dr. Anmol Mahal, gastroenterology. Conflict of interest statements were updated by Dr. David Gorslowski, dermatology, Dr. Scott Kramer, OBGYN, Dr. Anmol Mahal, gastroenterology. Reinstatement after leave of absence, Melanie Castro, physician assistant for Dr. Barry Rose. Withdrawal of application, Dr. Tulsidas Gavani, physical medicine and rehabilitation. Relinquishment of privileges, Dr. Bhupinder Bandari, gastroenterology, Dr. Andre Gay, orthopedics, Dr. Karishmasi Reynolds, orthopedics, Dr. Sukhwinder Sandhu, gastroenterology. And finally, resignations, Dr. Namrita Boparai, internal medicine hospitalist, Dr. Ricardo Da Rosa, hematology oncology, Dr. Daniel Joe, internal medicine hospitalist, Dr. Nitin Joshi, hematology oncology, Dr. Mayan Nguyen, nurse practitioner with the emergency room, Dr. Jiwoo Sun, internal medicine hospitalist, and Dr. Hui Zhang, family medicine.
Thank you. Entertain a motion for the medical staff credentials action.
Mr. President, I move for approval of the credentialing action items as presented by Dr. Killaroo.
Thank you. We have a motion and a second. Dee, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Aye.
Thank you. That motion passes. We now have a presentation. I'd like to have Kimberly introduce for us.
Thank you. It's my pleasure to introduce Dr. Bruce Lin. He is a practicing diagnostic radiologist in Fremont. Dr. Lin graduated from University of Vermont College of Medicine in 1995. He completed his internship, residency, and fellowship in vascular and interventional radiology. Before coming to Washington Hospital, Dr. Lin worked at Salinas Memorial Hospital for 4 years. He's been in practice at Washington Hospital since April of 2008, and he is medical director of the Vascular Interventional Radiology program, which he's going to talk with us this evening about.
Thank you. Thank you for the opportunity to present VIR at this forum. So tonight I'd like to endeavor to describe some of describe the specialty of VIR, vascular interventional radiology, to you, and to discuss a little bit of the program development here at Washington Hospital. So this graph actually it tells the statistical story of vascular interventional radiology at Washington Hospital from 2008 to current. And 2008 is when I was hired first to recruited to start the program. And we'll go into into the numbers a little bit later, but I want to first describe to you what are some of the procedures that constitute the numbers of that graph. So we've actually come a long ways since Dr. Charlie Dodders started the first angioplasty back in 1964. He's considered to be the father of vascular and interventional radiology. Since then, we have really expanded the scope of our practice, and we tend to develop them into different service lines because we cover so many organ systems. And most of our policies and clinical practice criteria are developed by the two societies, the Society of Interventional Radiology here in North America, and also CIRSE, which is the counterpart in Europe, the Cardiovascular Interventional Radiology Society of Europe. And those are the policies that we use to practice IR here. So the first service line I'd like to cover is the vascular service line. And it's interesting to note that when I first trained, my fellowship was actually called Vascular Radiology. Most people don't forget that interventional radiology used to be the vascular service line, and the society used to be called the Cardiovascular Interventional Society. Of course, that has gone away, but this remains a big part of our practice. And when you see the chart, the statistical chart and the volume for the cath lab in your fiscal report, actually a big chunk of that red piece of the pie that says vascular is where half of our interventional radiology procedures fall into. And so we covered the arterial system, from head to toe, in essence. Before the stroke program, we used to do all the cerebral angiograms, and now some of that is done by the stroke services. But obviously, the peripheral vascular disease in the legs is where we first started, and it's actually a passion of mine. And we have anything from the good old, we call POBA, plain old balloon angioplasty, to stenting, and now to more advanced tools like atherectomy to treat these diseases in even the small vessels in the foot. And I'd like to kind of highlight a couple procedures. One of them is carotid stenting, and this is a graphic depiction of that. You can see that when you have a plaque, does that show? The arrow doesn't show. So when you have a plaque in the carotid artery, we can cross it, put up a little umbrella called a distal protection device, balloon that, deploy a stent, and then we retrieve the umbrella, which basically traps all the debris and take that out. So this is a case that I had recently, someone who has a very bad blockage of the carotid artery that was having stroke symptoms, and he was not a surgical candidate, and so we ended up stenting him, and he's doing well. So another big part of the arterial service line is embolization. And embolization covers, basically it means occlusion of an artery or a vessel, and it covers a broad range of entities. And the most common one that we typically tend to see here is GI bleed, where this is an angiogram of the arterial system in the gut, and you can see a big bleed coming out of there. We would go in there and occlude the vessels to prevent bleeding. This is an aneurysm from the kidney, from the artery. This is a tumor in the liver that is supplied by a variety of arteries. And this is basically a rupture of the kidney. In trauma cases, this is what we would do. And of course, you have the arteriovenous malformations where you have a bad communication between the artery and the vein. And those are targets for us to perform embolization. And what do we do? What do we use to perform the procedure? These are the embolics that we tend to use. We have particles, plugs, coils, and liquid embolics. And these are some of the inventory that we now keep routinely in our cath lab. So at the other spectrum of the vascular line is the venous service line, which is also a growing part of our vascular service. And we go from the deep veins all the way to the IVC, to a variety of the vascular structures in the veins in the body. But there are a couple of things that I'd like to highlight just for this discussion. Is basically the DVT, which is clot in the veins, and the subsequent pulmonary embolism that can be fatal. So this is a picture of a vein in the arm, which comes to an abrupt stop here because there's complete clotting of the vein or thrombosis. This often happens in the legs, but it can happen in the arm. So one of the ways that we can treat that is to take a special catheter going to the clot, basically creating a jet effect, breaking it down, and then suctioning it back out. That's called a thrombectomy. Okay, so some of the devices that you come across are thrombectomy devices. That's what it is. And of course, we also have catheters that are used to infuse medication to melt clots, such as this one. This is a CT image of a pulmonary embolism. You can see a saddle embolus sitting right across the pulmonary artery. It's a pretty big one. In those instances, we would take a catheter, go from the neck, go through the heart, and then go into the pulmonary artery, park them inside the clot, and start infusing medications that can melt the clot and to resolve that the PE. So the other spectrum of the venous line is varicose veins. It's a very common thing, tends to be more patient-driven, and in essence, we're treating the bad, incompetent veins, typically in the legs, that cause the blood flow to reverse and pull in the legs. In the old days, we would strip them. Now we just take a catheter into the vein, and we use heat, such as laser or radiofrequency, and we basically ablate them. We seal the veins shut so that we don't have to strip them. What I like more is to actually use glue and put them into the vein, compress the vein, and glue the vein shut, and that's easier to do. So the other service line that is actually growing rapidly, probably the hottest growing service line in IR, is interventional oncology. Probably the largest service line now for IR across the world. And in this service line, we treat, other than the biopsies, which is the initial step to diagnose the tumor, we now treat tumors in a variety of organs. We can take a specialized needle and ablate, basically either heat or freeze a tumor in the lung, liver, bone, soft tissue, just about anywhere that you can go with image guidance, and basically produce cell death, or we can actually go into the liver and do liver-directed therapy, which is actually a very rapidly growing area of our practice. And I'd like to kind of highlight that a little bit. They're called chemoembolization and Y90 radioembolization. So when you have tumors in the liver, there can be either primary or secondary. There could be tumors that have gone to the liver, and they're typically supplied by arteries. And so the idea is to take a catheter, a small catheter going to these arteries, and release particles that can then embed into the tumor and can release either chemo. These beads are soaked in chemo agents, or they can be radiation beads that can emit radiation from inside the tumor, and as opposed to having external radiation. And so this is something that we are now growing tremendously, the Y90 radioembolization. It has less systemic side effects because the dwell time inside the tumor is longer, and the concentration is also higher when you deliver directly into the liver tumors. So this is one case where there's that tumor that is supplied by a variety of arteries. So our catheter is somewhere in here, we release the particles, and 3 months later we can see tumor death in this CT scan, and actually some shrinking of that area, the atrophy. So the next service line is women's health. So this is an interesting service line where tends to be more patient-driven and not so much referring physician-driven. And in these procedures, probably the most well-known is the uterine fibroid embolization. Some people will have some pelvic congestion syndrome. These are these bad varicose veins that instead of they're in the legs, they're actually in the belly, and can cause a lot of pain for women with multiple pregnancies in the past. And some people will have tremendous amount of migraine headaches. We now have ways to treat that more effectively. So I'd like to highlight the uterine fibroid embolization a little bit more because it's published a lot more lately. It's very patient-driven. And so this is a picture of a patient that I recently had, MRI, looking at the uterus, which is here. And she is plagued by a large uterine fibroid that is basically compressing her bladder, which is just a little sliver here, causing her to have to urinate frequently to the extent that she has to keep a catheter in her bladder all the time. Now, most of the time, the fibroids cause bleeding and pain, but some people, these symptoms are more bulk-related, and so this is one of those cases where they can get constipation because of the rectal compression or bladder compression. After embolization, you can see that entire fibroid has been devascularized. It's black because it's not taking up contrast, and the rest of the uterus, you can see it's bright because it's taking up contrast. And that's our goal. Eventually, this will resorb, and the uterus will shrink, and the bulk-related symptoms will improve. So angiographically, what does that look like? This is her angiogram. You can see The two arteries that come down the leg, these are the uterine arteries that are very big, very hypertrophy, because they're feeding that fibroid. The fibroid is sucking up a lot of blood. We take the catheter, go up and over, go into one of these arteries. You can see a selective angiogram. This is how big that fibroid is, just from the left side. We go to the right side. Very tremendous amount of arterial supply. We actually release particles into both sides to occlude them. And the final angiogram, you can see the disappearance of these large uterine arteries. So one of the fastest growing service lines for IR here at our hospital is actually spine, musculoskeletal, and interventional pain service line. So we perform, in addition to the typical compression fracture therapy, a lot of the interventional pain management, the injections that come with back pain, chronic back pain, joint pain, muscle pain, tendon pain. You know, if we can find it with a ultrasound or CT, we can put a needle in there, inject it. So we can go anywhere that we can see. We can also do some of the neuromodulation trials in implants and intrathecal pumps that are typically not done by IR elsewhere, but we have the ability to do that here. So I'd like to kind of highlight the most common thing that we do here, which is the compression fractures. And a lot of the elderly, particularly women, are osteoporotic. They often suffer compression fractures with tremendous amount of pain, and this is what it looks like. And most of them are insufficiency fractures. So instead of having them just in bed rest and have secondary morbidities that can develop from that, taking pain medication that can cause constipation and other things, we actually go in there into the compression fracture. We put a small balloon up to create a cavity, and then put cement into the bone to expedite the healing of that compression fracture. And in the acute cases where they come in probably within a week of the fracture, they usually can walk out the next day pain-free. The longer the fracture, the longer it takes to heal. So some cases, the fracture is caused by tumor, which disrupts the integrity of the bone marrow. And in those instances, we do something called an radiofrequency ablation of the tumor with something called osteocool. So we insert the osteocool antenna into the tumor, we ablate it using radiofrequency heat, and then we cement it. And the same technology is used, or the same concept is used for tumors elsewhere in the liver, in lungs, in breast even, in soft tissues, and kidneys. So in one of the more traditional service lines is our GU line, and in addition to the normal nephrostomy tubes and stents that the urologist will ask us to do, the newest thing is called prostatic artery embolization, or PAE. So this requires some collaboration from the urologist, but in some cases of the benign prostatic hypertrophy, it's too big and cannot be surgically treated, or the patient is not a surgical candidate. So in that instance, we translate the experience that we have in the fibroids and other embolizations. We actually get into the arteries that supply the enlarged prostate, like this one. This is the angiogram of one lobe, and we release particles to occlude the flow and to shrink that prostate, so that you don't have to get up 10 times every night to try to go to the bathroom, which can be very debilitating for us men. So one of the other more traditional service lines is dialysis access. This is not a very glamorous type of service line for us to do, but for me, I actually enjoy very much. It's a life-saving service line. The end-stage renal disease patients depend on the patency of the fistula in order to survive. And so, as routine or mundane as this may seem, it's very important. So the fistulas are typically created surgically by the vascular surgeons, but starting this year, actually next year, there will be multiple methods that will start to develop and grow where we can actually percutaneously create these fistulas without going to surgery. So that will be an upcoming, very interesting arena for us to tackle. And of course, we have the traditional, the hepatobiliary and the GI service line, where we put in tubes and lines into the intestinal tract or into the biliary system to help drain. So that constitutes the majority of our the scope of our practice. If you look at our coding sheet, we have over 300, 400 codes in the IR coding sheet, and that translates into separate procedures, but just too much to go into. Now, coming back to this bar graph, and this is basically the history of our program here, and you can see starting in 2008, that's when I came, there was very little growth. I was recruited by the radiology group to start the IR program, but I was thrown into the normal radiology rotation. So I was spending a lot of time reading films and could not really grow the service for those first 2 years. A bit frustrating, but I realized that I had to do something. So starting in the fiscal year 2010, I decided that I needed to make myself more available. So I gave my cell phone numbers to as many docs as I could and told them to call me 24/7. So I put myself on voluntary call, and you can see the effect of that. It was very difficult in the beginning, but it was worthwhile. The longest call trip I made was I was on vacation in Yosemite. I drove back to do a case and then drove back to Yosemite. But it was worth the initial phase of growth. Now, the second year after that, we're seeing a big growth in the outpatient side. And that is interesting because that was a year that we actually shut down our cath lab. We had to build our new cath lab, and we moved IR into W.O.W, that freestanding outpatient cath lab that I think UCSF uses now. And because of that, it was almost like a block time for me. The cardiologists were not using that. I didn't have to compete with a lot of the other specialties. I was able to bring patients in one after another, and there were 5 bays in there, and so the patients were able to be seen and be treated at the same time. The patient satisfaction rate was tremendously high during that time, and that actually resulted in the doubling of the outpatient volume during that time. And then we moved back into the main hospital, and unfortunately the building was, the W.O.W had to be shut down. But from that experience, I realized that I needed a space to see the patients so we can generate more outpatient volume. And so on my weekly day off, I started a clinic to see these IR patients for better and more longitudinal care. And actually that resulted in further growth of the outpatient volume, as you can see. Then the following year, the work became too much, so we introduced a new member to the team, and that is a PA. And because I was still reading films pretty much every day from 8 to 5, and then doing procedures after I finished my daily workload in diagnostic radiology, I needed someone to help me, and so the mid-level was able to be present in the hospital on the floors, which led to a significant increase in inpatient volume. And 2017 is when I decided that I just basically had to step out of that diagnostic radiology role because I couldn't do both jobs at the same time and do it well. And so the vision was to start a 100% IR practice, which is myself at that point. And so that was the start of that. But I was able to devote enough resources and time into it that I was able to hire my partner, Dr. G, Benjamin G. He joined me last year, and you can see the result of that growth with a second IR on board. And this is 2020, this fiscal year in Q1, we're already having a fairly good projection. So currently, if you look at our clinic volume, you can see the growth, which correlates actually with the outpatient growth of our volumes in the cath lab. And last but not least, a lot of the radiology, the IR procedures that we do is actually done in ultrasound and CT, not just in the cath lab. And so you can see the trend, and this is the year that I stepped out with a tremendous growth with dedicated time there. So currently our team consists of myself, Dr. G, 2 MPs. Richard is only in the clinic. Virginia, who is the coordinator scheduler, she's basically the glue that holds us together. So when she's not there, then things fall apart. And one RN, and our administrative director is Christy Holt. Thank you for your attention.
Thank you for your presentation. I personally learned a lot there. I had no idea there were so many different procedures done. That's wonderful. Any other comments from the board?
No, I just have to thank Dr. Lynn for all his great work over the last decade. I know
you.
I have several patients, many patients, who
Thank you.
have, some of whom are alive because of you.
Thank you, sir.
Thank you again. Very, very informative.
Thank you.
We're moving now to our reports. We're ready for a report from the Service League. Ruth, welcome.
Thank you. So the volunteers, we're just giving an update on our busy activities that we have participated in during the last month. And we do find our jobs enjoyable, so we enjoy the special events. So the special events that volunteers participated in last month, were Top Hat, Think Pink, the biennial Children's Health Fair, which was lots of fun, Employee Health Blitz, the diabetes screening, and the AAA screening. So we had volunteers that participated in all those events. And so we just want to say thank you to the organization for allowing us to be able to come out and be the face of the hospital to help move through with registration and to keep us moving forward in our community. Along with the health participation, volunteers are also encouraged to do their annual flu shots, their TB shots, and so we're tracking that. And so this year we have really worked hard with our assistant director for keeping track of those who have not complied, and those volunteers are being marked inactive, so they can't sign up for a shift until such time as they have completed their medical requirements, so that we're all following protocol for that. And last but not least, it's gift shop time of the year. And so we have now started our holiday sales. So this week we did the holiday sales for Christmas. And in December 2nd, 3rd, and 4th will be our masquerade. So we just ask everyone to come out and support and help the volunteers. Thank you very much.
Masquerade jewelry sale is always a highlight
It's a highlight. Yes.
many of our lives. Thank you for putting that on.
You're welcome. Thank you.
Dr. Killaroo.
Yes, sir. So, medical staff report, we have a grand total of 580 members in the medical staff, out of which 359 are active. And we have another 43 that are provisional active. And we have 28 allied health professionals on staff currently.
Thank you. Kimberly, we're ready for the
Yes, why don't we
hospital events report.
Exactly. So why don't we start with the hospital calendar?
Past health promotions and outreach events. On Monday, October 14th, as part of the Women's Health Strategies for Wellness series, Kimberly Alvari, Director of Food and Clinical Nutrition Services, and Sherry Plaza, Washington Wellness Center yoga instructor, presented Healthy Eating, Active Living. 11 people attended. On Thursday, October 17th, Washington Hospital hosted the annual Think Pink Breast Health Awareness event. The event featured a health fair and presentations by Dr. William W.O.W, General Surgeon and Medical Director of the Women's Center, Dr. Emi Yoshida, Radiation Oncologist and Medical Director of the Washington Radiation Oncology Center, and Anjali Rao, Washington Wellness Center yoga instructor. Dr. Victoria Leapart, gynecologist, emceed the event. 359 people attended. On Tuesday, October 22nd and Wednesday, October 23rd, Washington Sports Medicine hosted sports physical clinics for high school students at Washington High School in Fremont. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Doctors Russell Nord, Michael Golden, and Stephen Zahner provided the examinations. Athletes also received orthopedic screenings by certified athletic trainers. Each athlete paid $20, which will be donated to the schools for sports medicine supplies. 92 student athletes received physicals. On Thursday, October 24th, Dr. Nancy Stoll, Family Medicine, presented Overcoming Obesity. 11 people attended. On Friday, October 25th, Washington Sports Medicine athletic trainers hosted a first aid station during the Special Olympics soccer tournament at Glenmore Elementary School in Fremont. 315 student athletes participated in this event. On Saturday, October 26th, Washington Hospital hosted the biannual Children's Health and Safety Fair. This free interactive event provided families health information and resources available in the community. It also featured healthy snacks and a children's costume contest for scariest, most original, and adorable. This event was co-sponsored by Washington Township Medical Foundation and the Washington Hospital Employee Association. 182 people attended. On Monday, October 28th, as part of the Women's Health Strategies for Wellness series, Dr. Catherine Dow, Cardiology, presented Gender Matters, Heart Disease Risk in Women. 16 people attended. On Wednesday, October 30th, Dr. Eldon Eichbaum, Neurosurgery, presented Sidelined by Back Pain, Get Back in the Game. 24 people attended. On Friday, November 1st, Washington Sports Medicine athletic trainers hosted a first aid station during the Special Olympics soccer tournament at American High School in Fremont. 357 student athletes participated in this event. On Saturday, November 2nd, Washington Hospital hosted the annual abdominal aortic aneurysm screening. Aneurysms develop over time and may have no symptoms, but if one bursts, it can cause immediate and life-threatening symptoms. Dr. John Thomas Mahegan, vascular surgeon, interpreted screening results. This event was sponsored by the Fremont Bank Foundation. A total of 47 people were screened. Of the 47, no one screened positive for an aneurysm. On Tuesday, November 5th, Dr. Jennifer Chan, Thoracic Surgery, presented Advancements in Lung Cancer Detection and Treatment. 17 people attended. On Saturday, November 9th, Washington Hospital hosted the annual Diabetes Awareness Health Fair. The event featured a health fair including blood glucose, cholesterol, and blood pressure screenings, in addition to diabetic foot exams. Dr. Prasad Kata, endocrinologist, presented Standards of Medical Care in Diabetes. Dr. Jack Rose, neurointensivist, and Luan Sadweste, RN, co-presented Diabetes and Stroke, What is the Connection? And Dr. Amir Dashka, podiatrist, presented Diabetes and Foot Care. 101 people attended. 93 glucose and cholesterol screenings were provided, and more than 50 people received a diabetic foot exam. On Tuesday, November 12th, Dr. Seema Sehgal, Psychiatry, presented Anxiety, Stop Negative Thoughts. 67 people attended. Upcoming health promotions and community outreach events. On Thursday, November 21st, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present The Art of Relationships. On Thursday, December 5th, from 6 to 8 p.m., Kimberly Alvari will present Food is Medicine, Eat for Wellness, Vitality, and Longevity. Also on Thursday, December 5th, from 7 to 8 p.m., as part of the Diabetes Matters program, Anna Mazzei, RD, will present Italian Cooking. This presentation will explore modifying traditional recipes to make them healthier without losing their distinctive flavors. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of October was breast health and breast cancer diagnosis and treatment, which featured Dr. Bogdan Eftimia, hematologist-oncologist, medical co-director of the UCSF Washington Cancer Center and the Washington Cancer Genetics Program, plus articles on how nurse navigators help improve breast cancer care and predicting breast cancer using the Gale Model Risk Assessment Tool. The Washington Hospital Healthcare Foundation Report. On Saturday, October 12th, Washington Hospital Healthcare Foundation hosted the 33rd Annual Top Hat Dinner Dance. This event was graciously chaired by Drs. Rohit and Seema Sehgal and Fremont Chief of Police Kimberly Peterson. 650 guests joined us to raise funds for the new 3D mammography machine for the Washington Women's Center. This cutting-edge technology has been proven to produce clearer diagnostic images, making it easier for physicians to detect abnormalities, reducing instances of false positives and unnecessary biopsies. Generous sponsors and donors contributed $185,000 to support the purchase of this important technology. Planning is also underway for the annual Trees of Angels celebration, which supports hospice and palliative care. The tree lightings will begin with the annual City of Newark celebration on December 2nd. The Union City tree lighting will take place later that month, and the Trees of Angels celebration at Washington West, 2500 Maury Avenue, will be held on December 12th. For more information about these events or inquire about sponsoring Trees of Angels, please call the Foundation at 510-818-7350. As part of their community engagement philosophy, children and parents of Basis Independent School in Fremont created and donated 321 pairs of non-slip socks as a donation to our pediatric department. Sandeep Kaur, RN, and R.B. Doctor, RN, graciously accepted this charming donation. Washington on Wheels WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of October, WOW served community members at the following locations: in Fremont, the Family Resource Center; Bay Area Community Services, BACS; TCV Food Bank and Thrift Store; and the Irvington Presbyterian Church. In Union City, the Ruggieri Senior Center, Alvarado Resource Center, and Our Lady of the Rosary Church. In Newark, Solid Rock Community Services. These community partners provide social services to families in need and the homeless population. WOW provided occupational health services, including influenza vaccines, at Lee's Imperial Welding, a producer of structural metals; Mizuho OSI, a medical device company specializing in surgical tables; and Fremont Bank, a retail and commercial bank. These companies are located in Fremont, Union City, Hayward, and Livermore. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of October was 406. Internet and social media marketing. Washington Hospital's website serves as a central source of information. The hospital's employment section was October's most viewed webpage with 34,967 views. Washington Hospital has an active social media presence. Through these channels, we update the community with news on events, services, and patient care. Connecting with our community through social media continues to grow. Our activities on social media during October included several features focusing on Breast Cancer Awareness Month, including our most popular post, which was the story of an 81-year-old breast cancer survivor from Newark. Users can find us on Instagram, Twitter, and Facebook at Washington Hosp. InHealth, Channel 78. During the month of October, Washington Hospital's cable channel, 78 InHealth, captured new programming, including 2 Women's Health Strategies for Wellness series programs called Healthy Eating, Healthy Living, and Gender Matters, Heart Disease Risk in Women, and a health and wellness program titled Sidelined by Back Pain, Get Back in the Game. In addition, InHealth aired 3 health and wellness programs called Suffer from Sinus Problems, Learn the Latest Treatment Options for GERD, and Healthy Gut, Healthy You, a Diabetes Matters program on Asian fusion, a Women's Health Strategies for Wellness series program titled Women's Health, Planning for Pregnancy, and the October Board of Directors meeting. Awards and recognitions. Healthgrades has announced that Washington Hospital is again the recipient of its America's 100 Best Hospitals for Joint Replacement Award, and is the only hospital in the Bay Area to receive this recognition for 9 years in a row. The hospital also received America's 100 Best Hospitals for Orthopedic Surgery Award for the 3rd consecutive year. And Washington Hospital is one of 4 hospitals in the Bay Area to receive a 5-star distinction in cranial surgery for 2020. These recognitions are the result of Healthgrade's evaluation of performance at approximately 4,500 hospitals nationwide. The Pharmacy Postgraduate Year 1 PGY1 residency program began on July 2, 2012. One of the initial goals of the residency program was to receive accreditation by the American Society of Health System Pharmacists, ASHP, which was accomplished 1 year after the inception of the program. After an extensive on-site reaccreditation survey, the program was awarded the maximum reaccreditation of 8 years. Congratulations to the many people, including pharmacy preceptors whose hard work contributed to this success. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070, and please follow us on Facebook, Twitter, Instagram, LinkedIn, and YouTube.
All right. I also want to announce that for the Trees of Angels, the Union City tree lighting is going to be on December 4th at 6 p.m. at Union City Hall. So we'll get all the dates, but I know that one was we just solidified that date. So we've got that on the calendar. I also would like to present Employee of the Month, and it's Danielle Dina Tali. And she is the November Employee of the Month. Though nursing is a part of Danielle's family history, she didn't realize it until she was in high school. One day when she was talking to her mother about wanting a career that includes helping people, Danielle discovered that her grandmother had been a nurse. Danielle earned her BSN from the University of San Francisco in 2009 and joined our new grad program at Washington Hospital the following year. She worked on 3 West. Then, driven by her desire to learn more, Danielle took critical care classes and in 2014 was transferred to the IMC unit. Danielle has participated in lean workshops and was instrumental in getting the IMC unit ready for their new home in the Morris Hyman Critical Care Pavilion. Danielle has been a preceptor to nursing students and new hires. As a charge nurse, she runs the unit efficiently and ensures the patients get the high-quality care they deserve. Danielle has received many patient, family, and peer compliments for the compassionate care she delivers. She takes her time to get to know her patients and their families. And an example of how Danielle is willing to go the extra mile for her patients occurred last year. As a seriously ill patient wanted to marry his fiancée, so Danielle worked with his sister to organize a wedding which took place in the IMC. Both the bride and the guests wore yellow, isolation gowns, and everyone shared in the couple's joy. According to her manager, Danielle is always upbeat and ready to tackle whatever the workday brings. With her positive and friendly attitude, she easily establishes rapport and strong relationships with patients, family, and the care team. She is the true definition of a nurse and a perfect selection for our Employee of the Month in November. Thank you.
Thank you, Kimberly. We're ready now for a lean report from Donald Pipkin, our Chief of Strategic Management.
Good evening. I have the pleasure this evening to announce our latest recipients of Lean Leader certification. Certification really is about teaching key physicians and managers in the organization the critical tools and methodologies of the Toyota management system, or Lean, so we can continue to drive continuous improvement in the organization. Certification is not a short process. It takes about 12 to 18 months. There's both didactic training and on-hands experience, and then candidates are evaluated at each step of that process. And so what that involves is 8 full days of in-classroom education, participating in a value stream workshop where we map the current state and future state of a process, Kaizen workshops or an improvement workshop, and then acting as a team lead in various functions within those workshops as well. So with that, we have 45 certified to date. I believe Dr. Herskew is actually with patients, so we'll be sure to get him his certificate and pin afterwards. But with that, I'd like to invite Dr. Stewart and Kimberly up to the front and present certificates and pins first to Karen Duff.
Yeah, come in the middle, we'll take a picture.
And next, I'd like to invite up Sherry Kellen, one of our nurses in our infusion center. And last but not least, Walter Chodo, Senior Director of Ambulatory Care Services. Congratulations.
And now our quality report from Mary Bolron.
Good evening. Thank you. I'd like to be presenting the quality dashboard for quarter ending 9/19. We'll start off with the infection prevention indicators, and initially with our central line associated bloodstream infections. So these are patients that get an identified infection after having a central line placed. And we've actually overall had some problems earlier about middle 2018 and really looked at making some interventions around multiple areas to prevent central line infections, otherwise known as CLABSI. We have a downward trend. In this quarter, it came down even further. We actually have less than the number of expected infections for a hospital of our size and type. So while it was an issue earlier, it's we've been making a lot of changes to how we have been preventing these infections from developing by looking at medical necessity of the central line to be in place in the first place, looking at the kits and what we do when we change a dressing and making sure that the nurses have everything at the right spot at the right time and use those effectively, and are monitoring and doing audits on the whole overall bundle approach. So I think we're seeing some of that success from that. Catheter-associated urinary tract infections, otherwise known as CAUTI. This is something that continues to be a challenge for us. As you can see, we are still above the national benchmark for this quarter. So the shared nursing shared governance team and the entire clinical team that looks at these cases, we identify them fairly quickly in the hospital and try to get back to the people who are actually doing the care for these cases. And we work with Dr. Martin, our infectious disease consultant, to say, what could we be doing to bring this down? And so recognizing that this has consistently been above the national benchmark, we've actually implemented utilizing new devices that you can use for patients instead of placing an actual indwelling catheter. And that makes a big difference, because if the patient doesn't have the indwelling catheter, then you eliminate the risk of somebody developing a catheter-associated urinary tract infection. So we're trialing that on some units, and we'll be looking further at that. And we've also changed some other devices with how we do the day-to-day maintenance and cleaning for patients who have these catheters. And again, of course, looking at when a catheter is in place, reviewing it every 24 hours to say, does it actually meet medical necessity? Do they need this catheter? And of course, if they do, it stays in. If they don't, the plan is to get it out immediately. So I think moving forward, we'll hopefully see a decrease in this. I was looking at the October and November data prior to this, and we actually have 0. So I'm assuming that if we can get through the rest of the month in December, that we'll continue to see a decrease. So I think some of that bundle approach is helping us when we'll see better outcomes in this. MRSA in the blood, again, another bacteria that's very difficult to treat with antibiotics. We've had 0 of those in this last quarter, so that's actually less than what would be expected for a hospital of our size and type, so that's good. Same with vancomycin-resistant enterococci infections, otherwise known as VRE, incredibly difficult to treat with antibiotics, and we're continuing to go now for our 4th quarter with no VRE infections. So that's good. C. diff is something that we've had an overall hospital initiative looking at for almost over 2 years now, and we can consistently say now that this quarter we have another quarter, the 3rd quarter, where we've been below the national benchmark. So this means that we have less than the expected number of C. diff infections for a hospital of our size and type. And I'm actually excited to see that I think a lot of the efforts that we've made around making sure that patients have the right antibiotic at the right time, and if they don't need it, we discontinue it. Cleaning efforts throughout the hospital are really continuing to be sustained well, using bleach when we need to, doing appropriate cleaning and turning over rooms, giving EVS the time they need to be in there to do that, and also looking at are we testing patients appropriately so that we're not over-treating? I think we're sort of seeing where we have consistently seen some positive outcomes from that. And that's great for the patients because a lot of these patients are sort of high risk and sick to begin with. So the last thing you want to deal with is getting a C. diff infection that will affect your GI while you're here. So happy to see that. And we anticipate that will continue to stay under, meaning better than the national benchmark moving forward. Surgical site colon infections. This is something that is looked at on a national, state, and state level. We did not have any surgical site infections related to colon surgeries this quarter. And the same follows with the surgical site infections for abdominal hysterectomies. So overall, continuing to do really well with those procedures that are a little high risk for infection. And I think it's just really a reflection of what we're doing in the OR right at the beginning of the procedure, making sure patients get the right antibiotics, that we're following the guidelines and that we need to with even room turnover in the OR and with the precautions that we use to stop the spread of infections there. That's really what that ends up being a measure and an outcome of. Moving into our nursing sensitive indicators, when we looked at falls for this quarter, we are happy to report that out of almost 13,000 patient days, 12,933, we did not have a single fall related injury in the hospital, which is great. You know, we've had some adjustments to the new building and getting rounds exactly where we need them to be in as frequent, and so we've seen a decrease in that. I think that process has improved, and luckily we have no injuries. So hospital acquired pressure ulcers, which are sort of, as you can see, sort of been up and down. So this last quarter, we are above what we use as our CalNOC benchmark. This is actually two pressure ulcer developments that are stage 2 level. We looked at these two cases. They go through the wound care team and really look and see, you know, what caused this to develop. And unfortunately, these two patients were had longer lengths of stay, were nutritionally, you know, compromised, and sort of in a higher risk category, which doesn't mean that we're not saying that that's okay. It's just that when you have a higher risk patient population, we'll continue to look at what we can do specifically to address all the issues, making sure that the patients are moved frequently and appropriately, they're on the right type of bed, nutrition, all that. So those two cases will also go and continue to go through the review process, but it did put us above the benchmark. Our Joint Commission National Patient Safety Goals, continuing to do very well with handoff communication. This is something that is done by a sample of direct observation, making sure that when these patients move into to another level of care, that the healthcare team communicates appropriately to make sure that the next team taking over the patient's care really understands what's going on with the patient and the plan of care. Same with patient identification on direct observation. It was done on 99.8%, so this is one observation that missed on documentation for patient ID, but overall continuing, as you can see, to sustain patient ID being done when and where it should be. Same with procedure time out, and this is actually the same case. The patients, when they were about to have a procedure, when we sampled this and did direct observation, all the team was documented as using the timeout process well. So we're doing well with that. Hand hygiene, as you know, is something we've sort of dipped off at towards the middle of 2018, and we've been looking at really hand hygiene, as you know, is something that we'll always have to continue to look at. You're going to always have to make day-to-day efforts to make sure that it stays on the forefront as one of the major patient safety initiatives. So this quarter, at 85.1%. National average for hand hygiene is about 70%. You can read anywhere from 50 to 70%. And Joint Commission would goal is 90%. So we recognize that it is not acceptable to even be at 85%. So we're working with the medical staff, with the infection prevention team, executive leadership, and looking at what's the best way that we can do to get this on the forefront, maintain it on the forefront, and work as a multidisciplinary team to get education back out there about hand hygiene and do visual aids throughout the hospital, and even doing an audit system where we can work with people when we've identified that they haven't completed hand hygiene, and have a right away on that spot have a little conversation about recognize you weren't washing your hands. This is the expectation, and it's also a great chance to get feedback from people. When you talk to people when they have missed a hand hygiene encounter, that's when you tend to learn a lot about maybe issues. So you learn about availability. Maybe the Perel wasn't where it needed to be, or maybe they didn't think that they needed to wash their hands in that moment, and then we go back and use that as an educational opportunity for them. So we're beginning to roll out a new campaign on that, and hoping that that will increase for compliance. Our readmission rates for this quarter are starting off with pneumonia. Again, these are patients that are admitted within 30 days of being discharged with a initial primary diagnosis of pneumonia. Our rate came down below the national benchmark at 10.9. CMS as benchmark on this is 16.7. So these are 7 patients out of 64 patients that did come back. All of these cases are reviewed, and we go through the medical staff peer review process, and the readmissions task force is looking at those. We are glad to see that this area has come down a little bit on its readmission rate. AMI, otherwise known as a heart attack, continues to be a challenge. And these, we had 4 patients that came back out of 24. So in looking at these cases, which again go through the readmissions task force and medical staff peer review, we have, with these 4 in particular, they did not actually come back with cardiac-related symptoms. They did meet medical necessity, needed to come back, needed to have care in the hospital. So we admit them, of course, because that's what we want to do and make sure the patients get the care they need. But it's important to see, is there anything we could have done different in the discharge plan to make sure that these patients had everything they needed to transition into home or with home health care or SNF. So we are continuing to work on that with those patients. And again, the same thing with heart failure. This did increase, and it's been remaining above the benchmark. We had 14 out of 50 patients come back this quarter, which equals about 28%. These cases are actually one of the focus disease states of hospital reducing readmissions task force. And the key with these is really focusing on the transitional care plan. These patients are chronically ill, and we have to make sure that they have the right amount of support when they move into the care transitions that I just mentioned. So SNF, home health, or home. And so if a patient is readmitted, especially within 7 days of being discharged here, those are the ones we really want to look back and say, did we really do the right and appropriate planning, and what could we have improved on? So that's why we drilled down on each one of those cases to improve transitional care planning for future patients. Same thing with this. We did see an increase in patients who have a coronary artery bypass graft, CABG surgery. We actually had 4 patients out of the 10 that had CABGs come back. So this has been somewhat unusual for us. You can see the number of the volume is low, but still it's 4 patients who came back. And so the 4 cases are being sent through the medical staff peer review process. But in addition to that, we're looking and working with the care team that took care of these patients afterwards and while they were readmitted to ask the same questions. 2 of the 4 were complications related to a surgery that tend to be difficult to predict. They were low-risk patients, all four, when they came in. We do a risk calculator, and, the cardiovascular surgeons do a risk calculator and anticipate, does this patient have a high risk for having complications or mortality? And in these cases, they were low risk going in, a couple of unforeseeable complications. So we're looking at, again, what could we do? Could we have done anything to improve the process that we set them on going forward in their transitional care planning? But I want to emphasize that the main thing that you have to focus on, I think we get really focused on readmissions because CMS and there's big initiatives around it on a national level, and we don't want to ever expose anybody to the healthcare environment on acute care level if they don't need it. But if they do, and these four patients absolutely did, they need to be admitted, they need to be offered the medical treatment that is going to benefit them. And so while it's a spike, it's a reflection of the fact that they also got the treatment, and the four of them actually had good outcomes after that when they went home. And moving into knees. This is a knees and hips, as we all know, is one of the best service lines here for having great patient outcomes. And for this last quarter, way below the benchmark, only had one patient out of 130 who had knees and hip replacements who came back. That puts us well below the benchmark. And what's interesting about these patients also is they have a shorter length of stay while they're here, and they still, having said that, are very seldom readmitted. Moving on to chronic obstructive pulmonary disease, otherwise known as COPD. This is another chronic illness, very difficult to manage, and we have to make sure that these patients are getting appropriate planning prior to going, and that they have the appropriate pulmonary rehab follow-up, things like that. We're really focusing on now to make sure the patients can get what they need once they transition out of the hospital. This quarter is below the benchmark. We had 3 patients come back out of the 28 patients that were discharged in that quarter with COPD. So we're very happy to see that continue to go on a downward trend, and we'll be keeping the same focus, again, like with the other disease states, in transitional care planning, making sure that they get a good plan prior to discharge. That's it for those. Thank you.
Thank you very much, Mary.
Okay,
Are
thank
there
you.
any questions from the board for Mary?
Nope, thank you.
Thank you very much. We're ready now for a finance report from Chris Henry, our Chief Financial Officer.
Tonight we'll be looking at Washington Hospital's operational and financial results for the month of September. Looking at our acute inpatient statistics, average daily census for the month came in lower than we expected at 137.8 patients per day. We'd expected 154.5 in the month. Admissions came in right on budget at 908, one above budget at 918,000. But our patient days were 501 below budget at 4,135. And if you look down at the bottom line, it all translates into a lower length of stay in the month at 4.46. We'd expected 5.06. That's not necessarily a bad thing. It's better for our patients, and in some cases it can be better for us financially because we incur less cost. Outpatient observation equivalent days for the month came in at 163, 4 above the budget of 159. Looking at utilization, case mix index for the month came in lower than expected at 1.443. We expected 1.545 for the month, and that could have something to do with the lower length of stay. That's a measure of the severity of the cases we saw during the month. It indicates that the patients that came in were less acute and may have something to do with that lower length of stay. Also, length of stay right now is a big initiative with our nursing division and making sure that people aren't staying here longer than they need to. They don't want them to stay less than they need to, but they're trying to get them out in an appropriate period of time. So there's a lot of work going on around length of stay right now. Deliveries for the month were 5 below budget at 123. Our surgical cases for the month were 23 below budget at 339. That really was largely driven by our general surgeries. Our joint replacement cases for the month were 22 above the budget. Neurosurgical cases were 3 below what we expected. Cardiac surgical cases were below budget by 5. So really those numbers were really brought down by general surgery in September. Cath lab procedures for the month continued higher than budget. Got a good idea of what's going on with the program with Dr. Lynn's presentation tonight. There were a lot of work going on with Dr. Lynn and Dr. G really raising those numbers as we've seen all year. So we had 388 cath lab procedures for the month, 50 above the budget of 338. Outpatient visits for the month came in 974 above the budget at 8,026 visits. Those numbers have been higher all year. They're significantly higher than last year. I think a lot of the activity that's being driven in our cancer program is driving that. We're also seeing a lot more x-ray and really across the board outpatient visits are higher. Cardiac rehab program is running full steam. So a lot of activity in our outpatient service lines. Emergency visits for the month were 206 above the budget at 4,002 in September. A quick look at cath lab activity, as Dr. Lynn explained. He and Dr. G are involved both in the peripheral vascular and non-vascular interventional radiology service lines, and those two service lines really dominated the activity in the cath lab in September. Cardiac procedures made up 37% of the volume, and our neurointerventional radiology made up about 1%. A little bit slow in neuro IR in September. Looking at productivity, our productive FTEs for the month came in 14.5 below budget at 1,244.7. We had 202.9 non-productive FTEs in the month, giving us total FTEs that were actually 2 above the budget, largely driven by those non-productive FTEs at 1,447.6. Our full-time equivalents per adjusted occupied bed, which is our productivity measure for the month, came in a little bit higher than we had anticipated at 6.82. So a little bit heavy on staff for the month, but when we're having these kinds of fluctuations, it's tough to flex. Moving into the financials, first we'll look at the Governmental Accounting Standards Board presentation, which is the presentation used for our audited financials. Total patient revenue for the month came in about 4% below the budget at $159,500,000. Our total deductions as a percent of revenue, that's our contractuals and reserves for bad debt, came in at below budget at 76.35%. We'll look at the details of that. Really, our insured patient mix came in favorable. We had lower Medicare, Medi-Cal in the month, better PPO and HMO. So the contractual allowances for our patients that were covered by insurance came in at 73.18% of gross revenue, which is significantly better than we had expected in the month at 75.25%. The story here again is our provision for bad debt and charity. We've seen those numbers really elevated over the last six months, and they continue to run high. So our provision for bad debt and charity came in about $1.1 million above budget at a little over $5 million. But again, our total deductions came in better than budget at $121,772,000 or 76.35% of gross revenue. So we ended up the month with net operating revenue almost $500,000 above the budget at $38,183,000. Operating expenses for the month came in just shy of $1 million over budget at $38,877,000. Really two big drivers on that one. The biggest one really is our benefits were over budget by about $1.3 million. There's two factors contributing to that. I want to spend a little time on one of them. When we book our pension expense, we use an actuary to help us estimate what that number is, and there are a number of factors that go into that calculation. One of the most important of which is an assumption we call the discount rate. And what the discount rate is basically an assumed interest rate that the investments that are underlying that pension plan will earn over the next 30 years. Because of where we are in the investment cycle and the market cycle, our investment advisors recommended that we might want to lower that assumption to take a more defensive posture in our investment portfolio to try to protect a little bit more against downside in the markets. So what we've done is we've lowered that assumption from an assumption of 7.5% to 7.2%. So that reduction ripples through a number of calculations that the actuaries do for us, and one of them is the estimate of our annual pension expense. So the impact of that is their assumption is that our investments will earn less on an annual basis over the next 60 or 30 years than at 7.5%, and those earnings offset our expense. So we have less investment earnings offsetting our expense, and the impact of that is about $500,000 a month. We're going to see that adjustment flowing through the financials over the next 10 months. It's not something we could have anticipated in the budget. It is a base calculation, one thing I want to explain. If our investments perform better than that 7.2%, when we do our mid-year calculation, we'll be doing some adjustments to reduce that expense. If they perform worse, we'll go up. We've had these discussions with that calculation before, but about $500,000 hitting benefit expense that we weren't expecting in the budget as a result of this calculation. The other thing that's driving that $1.3 million is we continue to see a number of high-cost claims rolling through, and these are continual claims that have been rolling through for the last few months. The impact of that is about $823,000. So really that $1.3 million in benefits expense is driving our total expense variance. We do have some offsets to that. Our supplies for the month were $142,000 lower than budget. We were higher in our prosthetics by about $218,000. But pretty much everything else across the board were lowered in budget and offset that $218,000. And, you know, it's good to have that variance because that means our volume of joint replacements is higher. Purchase services and pro fees were lower than budget by about $323,000. That's largely driven by medical fees. We continue to have the fees that we pay to have our UCSF physicians here be lower. Their volumes are higher than we expected in the budget, and the revenues that are generated from those volumes offset those fees. So it's a good story there. You know, our PDC clinic, our prenatal diagnostic clinic, our oncology program, and our skilled nursing facility, our special care nursery really have been busier than anticipated, and it's offsetting those fees. Insurance, pretty close to budget for the month, but our utilities really are over budget in the month. Electricity particularly about $51,000. I think that's a function of us trying to guess how much it was going to cost to power a brand new building for a year. Now that we're getting some experience, I think we're going to be a little short on that for the rest of the year. You know, we're short about 10%, but on a 224,000 square foot building, it's tough to estimate. So anyways, we end the month with actually an operating loss of $694,000. About $500,000 of that really driven by an accounting estimate. So if you factor that out, we're pretty close to budget. Non-operating income for the month came in $408,000 lower than budget. We did have about a $600,000 unrealized loss on our investments driving that variance. So we end the month of September with a total bottom line from a GASB perspective showing a loss of $1.149 million. Looking at our Financial Accounting Standards Board format, and this is the way financial markets might adjust those GASB financials when they look at us. We do remove our interest expense. We remove our income that we earn from tax revenues to service our general obligation bond debt service. And also we remove the interest related to that completely. So we reclass the revenue bond interest back up into the operating expenses. That results in operating expenses about $865,000 above budget and an operating loss of about $1.4 million. And it changes our non-operating income actually pretty close to budget to $591,000. And a net loss from a FASB perspective of $827,000 for the month. Quick look at earnings before interest, taxes, depreciation, and amortization. Again, for those who aren't familiar with this, this is a way of looking at our financials to kind of estimate the cash that the operation and not operating activities are generating to provide for debt service and future capital needs. We look at our operating expenses excluding depreciation to adjust to EBITDA of $3.364 million in the month. We also remove that interest expense from our non-operating activities to come up with non-operating income of $1.4 million. So we ended the month with about $4.8 million of earnings to cover the debt service on our borrowings and future capital needs. Any questions on September?
Like we're ready for the operations report.
All right, I will give the October operations report, starting with the gross revenue. As you can see, gross revenue of $174.1 million for October was below budget by $2.7 million, or 1.5%, but above the budget of 2018, but above the actual of October of 2018 by $3.1 million. Inpatient gross revenue of $116.2 million was below budget by $5 million, or 4.1%, but $260,000 above October of 2018. And then outpatient gross revenue of $57.9 million was above budget by $2.3 million and $2.8 million above the October of 2018 actuals. Looking at our major drivers of revenue variance, once again, cath lab has been very busy. We've had cath lab procedures were above budget by 133, or 37.4%, driving cath lab revenue up by $2.1 million. Inpatient days were below budget by 267, driving room and board revenue down by $1.9 million, or 5.7%. Surgical cases were below budget by 27, driving surgical services revenue down by $4 million. The higher level of outpatient activity once again drove ancillary services revenue above budget by $1 million, or 1.3%. Looking at our key census statistics, our average length of stay of 4.82 was below the budget of 4.93. Again, as Chris had mentioned, we've been focusing on looking at our appropriate discharges and length of stay. Our outpatient observation days were 4, or 2.3% above budget at 175 days, and our average daily census of 145.1 was below the budget of 153.7 by 8.6, or 5.6%. Looking at our admissions, our trend admissions were below budget by 17, or 1.8%, and admissions for the month were basically about the same, or were 1 above the budget, or above the actuals of October of 2018. Our patient days, again, patient days of 4,497 were below budget by 267, or 5.6%. Our surgical trend, Total surgical cases in October of 371 were below budget by 27 or 6.8%. Our inpatient surgeries were 11 below budget at 231 and 20 below the October 2018 volume. Outpatient surgeries were 16 below budget at 140 and 11 below October of 2018. Looking at the breakdown of our surgical activity, our general surgical procedures were below budget by 22 or 10.6%. Our joint replacement surgeries were below budget by 9 or 5.8%. Our cardiac surgery surgical procedures were on budget at 10, and our neurosurgical procedures were above budget by 4 or 15.4%. Continuing with our cath lab trend, again, our cath lab procedures for October of 489 were 133 or 37.4% above the budget, and 62 or 14.5% above the actual for October of 2018. Our inpatient cath lab procedures were above budget by 116 or 58.3% at 315 and 82 above October of 2018. And outpatient cath lab procedures were above budget by 17, but below the prior year by 20. So that cath lab volume continues to be our cath lab busy. Looking at the broken down by the types of cath lab activity, we have our neuro-interventional radiology procedures were above budget by 1. Our cardiac procedures were above budget by 6. Our non-vascular interventional radiology procedures were above budget by 24, and our peripheral vascular procedures were above budget by 102 or 69.9%. Deliveries, we're still trending below budget by 6. October was 123, and deliveries were 13 below October of 2018. Non-ER outpatient trend, this is another area that we've continued to see quite a bit of outpatient visits. Again, non-emergency outpatient visits of 8,748 were above budget by 765 or 9.6%, and these were above the October of 2018 visits by 803. The breakdown of the increase in these visits, so hyperbaric visits were above budget by 49 or 132%. Outpatient wound visits were above budget by 50 or 15%. Infusion center visits were above budget by 67 or 20%. X-ray visits were above budget by 142 or 6.8%. And lab visits were above budget by 264 or 9.2%. So that's what's driving the increase in our outpatient activity. Looking at our emergency room visits, they were above budget. We had emergency room visits of 4,284, which were above budget by 62 or 1.5%, and were above the same period last year by 237 or 5.9% visits. Looking at our productivity indicators, our productive FTEs were above budget by 72.5 at 1,349.1. Our non-productive FTEs were below budget by 4.8 or 2.8% at 164.1. Our total FTEs of 1,513.2 were above budget by 67.7 or 4.7%. And our productive FTEs per adjusted occupied bed of 6.21 were above the budget of 5.69, and our total FTEs per adjusted occupied bed of 6.96 were above the budget of 6.44. So we didn't do as good of a job this time of flexing down, so we are looking at that and what we can do in terms of with our volume when it dips to ensure that we can flex down. Looking at our operational statistics, Washington outpatient surgery cases were on budget in October at 507, right on budget at 578. This was 44 or 8.2% above the October 2018 volume. Our clinic visits were down 8.7%, or 380. We did have a number of physicians that were out on either vacation or doing some CME this month, so that was one of the main causes of driving the clinic visits down. Looking at our preliminary payer mix, our government-sponsored patient revenue made up 73.4% of total gross revenue, which is above the budget of 71.4% and above last year's percentage of 70.9%. Our HMO revenue was 2.3% of gross revenue, which is below the budget of 2.5%, but higher than last year's percentage of 2.1%. Our PPO revenue was 22.2% of gross revenue, which is below the budget of 23.8% and lower than last year's percentage of 24.8%. Our private pay revenue was 2.1% of gross revenue, which is below the budget of 2.3% and lower than last year's percentage of 2.2%. Looking at our key financial statistics, our days cash on hand for October ended at 161 days, an improvement of 2 days over last month. Our days of gross revenue and accounts receivable were 52. There were $383,822 in charity care applications that were pending or approved, and you can see that is significantly down from the prior month. Let's see, and lastly, in terms of our summary of homeless patient activity, there were 220 homeless patient encounters in October 2019. Estimated incremental cost of Senate Bill 1152 for the month is approximately $124,000. Estimated total unreimbursed cost of homeless care for the month of October is $519,000. And estimated total unreimbursed cost of homeless care for fiscal year 20 year to date, as you can see, is about $1.7 million. So those are the statistics for October.
Thank you very much. Thanks to both of you. We're now moving into our action items. We have an action item A that Dr. Eapen will present.
Mr. President, I move for the adoption of resolution number 1200, whereby the Board of Directors approve the terms agreed upon between Washington Hospital Healthcare System and the California Nurses Association and enter into a memorandum of understanding in accordance with the resolution number 331A.
We have a motion. Do we have a second on that?
Second.
We have 2 seconds? That'll work fine. Now, Kimberly, if you'd like to explain this action item to the public and to...
Yes, I'd like to do that. We've been in contract negotiations with our California Nurses Association for a couple of months, and we concluded them successfully on Thursday, October 24th, and our members of the union voted to ratify the settlement terms on Wednesday, October 30th. I'm pleased to report. I want everyone to know that our CNA bargaining unit consists of registered nurses and has approximately 515 employees and approximately 270 per diems for a total of about 785 members. We did use an external compensation consultant to review our compensation plan compared to the marketplace, and in terms of ensuring that we can recruit and retain our nurses. And the increases that we have negotiated and that were ratified that we are presenting tonight are in line with the market, in line with our philosophy of not being at the top of the market and being not nor at the bottom. And that the budget funds that we provided for 2019 will cover the costs that are being proposed to you tonight. We are proposing the contract a 4-year term that starts July 1st, 2019 through June 30th, 2023. It provides for wage increases over that term. The first year of the contract covered by this contract will save a 3% across the board. The second year is a 2.5% across the board increase. The third year is a 3%, and the fourth and final year is a 2.5% increase across the board. We also looked when we did our market comparisons in terms of looking at the different differentials for the different shifts and how they compared to market. And we did make some increases in that in order to stay within our market. As we know, it's important to be able to recruit and retain and our nurses to be able to work those evenings and night shifts too. So you'll see that. The other some of the other areas that we focused on are training, and training is important as we continue to look at. It's of course difficult to at times recruit in this into the Bay Area. So when we have nurses that have been here that do want to do some additional training, we have been able to designate 6 trainee classifications over the course of our contract. With budgetary, considerations permitting, in doing some training in critical care, OR, ED, cath lab, our IMC unit, and OB. We also looked at, some of the other types of non-financial benefits in terms of education leave and alternative work weeks that are outlined here. So I do want to just thank the negotiating team, both from the administration side but also from the nurses side. I think that we came to a very fair agreement that I'd like to propose here tonight.
I think this is really good news. Mm-hmm. Really, really good news. It's nice to have that settled nicely.
Yep.
Any other questions from the board at all? Then we'll take action on that. Dee, if you take a roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Aye.
Good. That action item passes. Kimberly, do we have some announcements that we need to take care of before?
One announcement that I'd like to quickly make, and that is, as we've discussed in the past, Washington Hospital and UCSF are jointly proposing to locate a new outpatient center at 45388 Warm Springs Boulevard. And this is in the Warm Springs Innovation District. And as you know, we are always continuing to look at ways to expand and to be in our community and grow with our community. And this is a project that moving forward would need to be rezoned. And so the project did go to the City Planning Commission on October, I think it was around October 24th, and passed with a 5-0 vote. And it does need to go to the City Council, I believe, December 10th. So I just wanted to make sure that everybody was aware of that. So,
thank you. That's good news, too.
Yep.
We'll now adjourn to a closed session. Thank everyone for attending this evening. At this point, we're reconvening to an open session, and I want to report that the board approved a lease for approximately 9,500 square feet of space located at 350 Marine Parkway in Redwood City to accommodate an outpatient surgery center and the expansion of our Institute for Joint Restoration and Research. That concludes our agenda this evening. This meeting is now adjourned.